This is a little bit like reading the last chapter of the book and then going back to the first chapter. But I think I'd like to start it off by, there are some books that you do need to start reading in the middle. For example, our president's autobiography starts on chapter 11, which is the government code for bankruptcy. So his career started with that. So this is a bankruptcy chapter, if you will. This presentation was put together by one of our favorite people, Akshay Sood, and it goes into what went through my mind when I was conceptualizing robotic kidney transplants, and the work that we did preclinically to model robotic kidney transplant, fully understanding that these were baby steps and that these would undergo modifications as you have seen. As I went through my mind, certain things were obvious. Number one, I might think about the procedure, but I shouldn't be doing the procedure. It had been 19 years since I had done a kidney transplant. United States laws decertified me. I couldn't do a kidney transplant in the United States. I had to work the techniques out in my mind and in the cadaveric lab, and then I had to collaborate with someone to get this done. And we invited 3 people to collaborate. Dr. Bandari was involved in doing this. It was Rajesh, and he said, just come and we'll make this happen. Pranjal Modi said the same thing. The third person we called, who was technically just as gifted, was hesitant. He could have been Deepak Dubey talking, and he raised all the questions and all the issues that could happen if you weren't careful. So gratitude to Rajesh and Pranjal for doing this. We then had a fellow, Akshay Sood, who was responsible for collecting the data. I couldn't get away with not having immaculate data in our institution, and I had to get the institution's permission to go somewhere, even if I was just helping someone else or conceptualizing the procedure, because of our legal issues and malpractice coverage. So that was difficult to get approval to do a procedure that I wasn't credentialed to do in the United States, in another country, and to get malpractice coverage. We did. As I thought through myself, I said, if I was doing a transplant, what are the things that I could bring to the table? And the first thing was the gel point. At that period in time, the gel point was hardly ever used in urology. So for about 2 years, we used the gel point to do radical retropubic prostatectomy, and the theory being that through the gel point, we could introduce ice around the neurovascular bundle and decrease postoperative inflammation. So this is what I had to submit to the IRB to allow us to do that technical modification. I then felt that every radical prostatectomy, we did a lymphadenectomy. So if I just put the kidney on top of the bladder, the vessels should sit exactly where they should be. And this we could model in the cadaver. And the third thing was we needed to make sure what the transfer of cold was, what happens to the bowel, what happens to the core temperature. And before we did the first transplant, we had done 500 prostates where we put ice into the pelvis, over the vessels, over the bladder, and verified that there was no transfer of cold to the organs. Now, maybe if we had done 5,000, we would have seen it, but we didn't at that point. So this followed the model of surgical innovation. Without innovation, surgery will die, but careless innovation can cause patients to die. And so innovation has to be responsible. Outcomes should be measured accurately, and there should be worldwide adoption ultimately. In concept, minimally invasive surgery reduces pain minimizes postoperative morbidity and complications in comparison to conventional surgery. When we started doing robotic prostatectomies, we heard the same concerns that you heard today. You can do an open prostatectomy through a 5 centimeter incision. You add your port sites and it's 3.5 centimeters. Is it worthwhile buying $1 million robot to save a 1.5 centimeter incision? You don't have tactile feel, so you can't feel where the nerves are. So if you do anything minimally invasive surgery, all your patients are going to be impotent and incontinent. Well, none of these ended up by being true, and some of the people who said these things ultimately ended up by being the greatest proponents. Minimally invasive surgery has been known to decrease postoperative pain. As I alluded to, this has never been shown in a randomized controlled trial, yet most gallbladders are done minimally invasive and most prostatectomies are done minimally invasive. Transplant recipients are fragile and immunocompromised, and patients undergoing a kidney transplant are greater risk for developing postoperative complications than an average surgical patient. Numerous studies have shown that renal failure is an independent predictor of complication rates. And these complications not only translate into convalescence, but also patient survival. Thus, transplant recipients stand to gain substantially from MIS. So this is the theory that got behind the thinking. I had no data to support this. So we came up with a plan to do this, and it turns out that the model that we used fit the criteria of the IDEAL collaboration. IDEAL has set up IDEAL, stages of surgical innovation. This is a group of thinkers from all over the world who met at Oxford University, and they published this. And within a month, we sent them our transplant paper where independently we had thought across about the same steps. And this ends up by not only being the first robotic kidney transplant paper, unselected patients, but also the first IDEAL paper on their website. So the way IDEAL suggests a procedure, any new procedure be developed, would be to use a small number of patients for a proof of concept. So Dr. Kishore, you have done the IDEAL stage 1. I mean, you've gone beyond that, but if you had done 10 patients, highly selected, not obese, with your procedure, I think you would have done an IDEAL phase 1 study. And what it also shows, what we added to the IDEAL phase 1 is before you do all of this, you can go to the cadaveric lab and model all of this. And you know, we talked about this, and by doing the modeling, I think you can gain something. From your presentation, I thought of a completely random application for your procedure, and I think we briefly talked about that. And that is for robotic hernia repairs. Gallbladders and hernias are the #1 robotic procedures in the United States. Now, did he just show us the best way to do a hernia? Open up the peritoneum between the medial umbilical ligaments, develop a space, put a mesh in there, and sew it up. The hernia will be done in about 15 minutes. Now, maybe they're already doing that, you know, but this looks like a good way of doing it. They are doing it. Okay, so the early studies are stage 1 to stage 2. A randomized control trial would be a stage 3 if you really wanted to have the proof of principle. And stage 4 will be multiple randomized control trials with long-term follow-up. So in stage 1, we simulated pelvic hypothermia in the robotic radical prostatectomy model. This is what I said. So before we did a first kidney transplant, we modeled the safety of regional hypothermia. We put varying quantities of ice in the pelvis. We measured the core temperature, had the anesthesiologist measure it. We saw how long 240 cc's of ice or 120 cc's of ice will last before the body temperature went up. We did it thinking that we would improve erectile function. We didn't. The second stage is working in the cadaveric lab, and Rani Abaza kindly provided a cadaveric lab. Dr. Bandari and I went to Ohio State and did 2 procedures where we put the kidney in one fossa, we put the kidney in the other fossa. We did bilateral transplantations. We tried putting it orthotopically, and then what we could learn in 2 cases was that putting it on top of the bladder naturally led the arteries and the veins to the external iliac pedicles and made the anastomosis simple. We knew that that wasn't where we were going to end, but that was a good beginning for the first few clinical patients. And somebody talked of the QSUM study, and that's part of the statistical process control that we did in monitoring the data. Key to us was getting the data monitored. This is where I think Dr. Alawat needed some help in getting the data monitored accurately. Dr. Modi was unable to do it, and so I have no access to the Ahmedabad data beyond the first cases that we did with him. Stage 2A is technique modification and standardization. Kishore, if you had a robot in 2013, we would have worked with you, and then we would have standardized the procedure using different approaches. Procedures have to develop. There has to be surgical innovation. I am not here to say that what we did in 2013 is where we should end. It should not be. If it ended there, then we're really not thinking, we're really not trying to improve what we're doing. And we need to measure the outcomes. Stage 2A and B is the dissemination and evaluation of individual approaches and mentoring, and I think Rajesh is going to talk about that. So here is a study, and notice this is the preclinical study measuring changes in body temperature. And essentially, it shows that the changes in core temperature, the blue line shows 15 minutes of icing, and then the red line shows 15 to 20 minutes of icing. And what it showed is that from case 1 to case 30, and we could have done it for 200 cases, there was no change in body temperature. The temperature did not drop. Why did we do this? I didn't realize that the anastomosis would be this easy and this reproducible. I figured it would be in Dr. Alawat's hand, but I didn't want him to be working against a ticking clock, saying, I've got to get this done in 15 minutes or 20 minutes. I wanted the kidney to be cold. We know that up to 4 hours of cold ischemia in a normal kidney is tolerated, or even 6 hours. So let's take away the tenseness factor and make the anastomosis go smoothly. And again, we saw that cold ischemia was good in over 300 patients studied over a 2 to 3 year period. You don't waste any information. So I've used this technique for cooling kidneys for complex renal tumors. All renal tumors, or most renal tumors, can be done easily by expert surgeons. But part of my role is training people. Complex renal tumors are not done easily by novice surgeons, and you need to give them a safety net, which is clamp the kidney, cool it, and then do whatever tumor you need to remove, and take as long as you want to reconstruct it. Turn off the clock where you're measuring ischemia time because you have cooled the kidney. So there was, yeah. We then wanted to see if the anastomosis would be patent, and this is a cadaveric dissection we did. We took out the anastomosis and had the pathologist look at it, and they showed no evidence of stenosis in the technique that we did. And all of this was done in the month before we went to Medanta. And then we did 2 cadavers, 4 auto transplants. When Ronnie Abasa decided to come to Delhi, he was uncomfortable with just doing 2, so he did 2 more on his own, 4 cases, and worked out the sutures. We didn't know that the Gore-Tex suture was going to be good for the anastomosis, and you saw how the Gore-Tex doesn't have any memory. Maybe that was available, but our transplant surgeons did not use Gore-Tex. They were using Proline. So experimenting with different sutures and making sure that no time was wasted, that there was no memory, that you could take one Gore-Tex suture and split it into 2 and make 2 anastomoses, all of that was experimented during Dr. Bandari's and my visit there. I think I might stop here because you'll be talking about most of it. So these are the first cases. These are the technical modifications we did, and I'm sure that these modifications go to the first 16 cases, and then they would go beyond that. For the phase 1, which was in January 2013, we got IRB clearance. For stage 2B and 2A and 2B, we are continuing, and I think Dr. Alawat is planning on starting a randomized controlled trial. I don't know where we stand with that. And you have these. This is an overlap, right? This is the 700. You don't have that? Okay. So shortly after you started, Kishore, by 2015, Akshay found 772 patients who underwent kidney transplant in the centers that were part of this consortium. 118 patients were excluded for the reasons mentioned.
It's all Medanta data.
This is all Medanta data. This is all
Single
Medanta
center.
data. Okay. So then, if you have it, then why don't you? Yeah, because I think we were unable to get Pranjal's data, so it's all Medanta's data. I thought some of Breda's data were there too. No. Breda's data is not here.
Yeah.
Breda, okay, so, okay. And 654 patients were eligible for the study. And then Dr. Alawat and Dr. Sood did a propensity matched analysis of 504 patients. 126 actually underwent robotic transplants, and 378 underwent open transplant. This is a typical open incision. I don't know that this is Medanta. I don't know where Akshay got it. And this is a typical robotic kidney transplant incision. Again, as you see, our incision was through the midline and have the gel point over there. The operative time was significantly longer in the robotic cases, by about 30 minutes, which translates into extra cost. Of this, 154 minutes was console time. The warm ischemia time was no different. The cold ischemia time was significantly more with the robotic transplants. Rewarming time was significantly more. However, in this propensity matching, we found that the blood loss was significantly less. The incision was much smaller, and only one person needed to be converted. And I'm not even sure that that person, I think it was, again, one of those capsular bleeding hematomas that we had to explore with vascular spasm, which happened in the first 10 patients. In the propensity matched patients, there was significantly less pain postoperatively, statistically significant. Whether this is clinically significant or not, we don't know. But you can see that the confidence intervals do not overlap until you get to 104 days. So patients are having less pain by and large. And the pain was less at 12 hours, 24 hours, 48 hours, and almost significant at 96 hours. So essentially the benefit that you're getting is an early postoperative pain. What we could look at it a different way. Pain control was excellent in the Medanta group. Fantastic anesthesiologist, nephrologist, nursing. But the amount of medication that was used was far less in the robotic patients. Much less IV fentanyl was required for pain control. No one had an epidural or needed an epidural, and much less use of intravenous narcotics. And the functional outcomes were comparable. It was non-inferior. So we were not doing a fancy operation that resulted in decreased graft survival. With the exception of lymphocyles, which was lower with the robotic transplants. Significantly, nothing else. Rejection-free survival, no difference in that. So that's all a non-inferiority. Graft survival, overall survival, no differences. Delayed graft function, there was a trend to better or less delayed graft function in the robotics, but it did not achieve statistical significance. No difference in the graft biopsy rate, and no difference in the re-exploration rate. If you lumped all the complications together, the complication rate was significantly less. But if you broke it down into individual components, the only difference we found was in lymphocyles. So we concluded that there was less bleeding, a smaller incision, lower postoperative pain and narcotic use, reduced wound complication and lymphocyles as compared to traditional open kidney transplantation, and the graft function, rates of rejection, and overall survival were not inferior. As of 2000, I don't know whether this 2015 or it's more updated, over 15 centers had participated in this and sent the data to Dr. Alawat. Yeah, so Kishore, you are in there, Aster Medicity, so you also, some of the data, the long-term data is part of yours. And it's truly been an ideal demonstration of the ideal surgical approach to developing kidney transplants. Thank you.
Couple of things.